As you know, PSIM is always working for the research and academics. And the purpose of all these sessions is to improve the patient health care and management. For this, we have organized 3 different problems in this session. First of all, I would like to invite Dr. Raja Farhat Shoaib. He is consultant stroke medicine specialist and neuro rehabilitation specialist, Shifa International Hospital, Islamabad. He will be talking about acute management of stroke. Please welcome Dr. Raja Farhat Shoaib.
Bismillah ar-Rahman ar-Rahim and Assalamu alaikum. First of all, thank you very much, Professor Javed Akram and rest of the organizing team for providing me with this opportunity to be here in this esteemed gathering of highly intelligent people. Slightly change of taste, as we have already discussed in intro. In next few minutes, we are going to discuss some recent advances in stroke care and where are we from Pakistan's point of view. So I will just start with a couple of examples. First of all, from the city where I am practicing with quite a few of my colleagues who I can see sitting here in the hall. Rawalpindi, Islamabad is the capital city of Pakistan with population of around 4 million. So it's an estimate, not the exact, but we see around 10,000 new strokes every year. But what sort of services we have got for stroke patients? At the top, you can see we have got Shifa International Hospital and Military Hospital. So these are the 2 centers who are offering fully comprehensive stroke services in form of thrombolysis, thrombectomy, acute stroke unit, and dedicated stroke specialist and stroke clinics. Total number of admissions that we take at Shifa is around 500 to 600 a year. MH, yes, it's a very good resource, but it is primarily from our armed forces. Rest, they cater for few private patients from the twin cities of Rawalpindi and Islamabad, and their private burden in terms of admission at their hyperacute stroke unit is around 300 to 400 per year. Then we have got Maroof and Fauji Foundation. They are doing excellent job. They have got TPA, they have got stroke services, they have got stroke specialist Hashim and Wakar. They are doing excellent job there. So basically, they do drip and ship model if a patient needs thrombectomy. And from admission point of view, these 2 hospitals are admitting around 800 in total. Fauji Foundation 500 and around 200 to 300 at Maroof. Then the 5th and the most important is that corner hospital, that is Rawalpindi Institute of Cardiology. They are doing excellent service in public service, in public sector. In terms of like thrombectomy. But the issue over there is, they have got a stroke specialist, but there is no inpatient services. So all those patients who qualify with large vessel occlusion for thrombectomy, they get excellent results out of that. But there are many patients who come to their door, but they are not candidate for thrombolysis, and they are deflected out. So these are those patients who actually need some extra care. Because jisko thrombolyze ho gaya, jiski thrombectomy hogi, you have given them something already. But those other patients who have not been given all these modern treatment, they need extra care. And unfortunately, they are deflected out. So if we take a total of these 5 institutes in Rawalpindi and in Islamabad, around 2,000 in maximum which we admit. What happens to rest about 8,000 patients? They are either admitted to any private institutes or other general medical takes them, or even under neurosurgeons. So just a sort of a humble request from here, all those who can do something, we need more stroke units wherever we are working. If we have got playing fields, everything will come, inshallah. Then a humble comparison, place where I was trained and place where I am working at present, City of London, with a population of around 8 million versus 4 million in Rawalpindi and Islamabad. Stroke incidence over there because of better healthcare is around 120 versus 250 in Rawalpindi and Islamabad. Sort of a same number of strokes, but what we have got, they have got around 8 hyperacute stroke units strategically located in different parts with around 112 beds and further 16 acute stroke units who are enabled for thrombolysis. So in total, around 350 plus monitored stroke unit beds. With 3 inpatient rehab and lots of other step-down rehab beds wherever patient is being treated. But we don't have got a single public sector stroke unit in Rawalpindi in Islamabad, no single stroke rehab unit. We have got sort of a same situation in other big cities, and situation is even worse in smaller cities of Pakistan. Why it is important? It's not only disease of elderly. In our clinical practice, I'm sure you have seen, we see lots of young adolescents, and especially in our society, we are not health aware. We've got lots of cardiometabolic issues that we are discussing today. We are seeing lots of young age group, working age groups, males and females coming to the door with all this disability. And in our case, it is not the patient who suffers, it's basically whole family that suffers because we have got no social setup at all. Just a bit of history, I mean, in the past, even in the established healthcare setup of Western Europe and Northern America, all strokes, they were treated either in nursing homes, and it was on discretion of GPs whether to admit or not to admit. But now it is hyperacute emergency. I remember as a fellow, 9 out of 10 times I used to take patient directly out of this vehicle so that I reduced door to needle time at that time, about 11, 12 years ago. But now there's a concept of mobile stroke units where they are thrombolizing even in community. 3 important factors that are important for all young doctors who are sitting here. First, early recognition and rapid transfer. Early we act, better we are. And then the most important, we have to collaborate with our emergency department, because that is the golden hour where we have to make all decisions, we have to do all treatments, and we have to channelize our patient where to go. Either we have to treat patient with us, or we have to ship them somewhere wherever there is appropriate treatment available. And then the third and the most important, stroke unit. Wherever we are working, we need to start working on those. Because stroke is the leading cause of death. This is CDC from America. At this year, this is 5th leading cause of death, but this is the area where the stroke-related disability death is less than 10%. In our case, it is around 30 or even 40%, but our data is not accurate. So in our case, it is actually more disabling, and we have got more death associated with it. Again, it's on its own leading cause of disability, and as I said, we don't have got any healthcare setup in terms of like social setup, so it's not only patient who suffers, it's the whole family that suffers. We don't have got any epidemiological study because we don't have got units, but estimated to 50 per 100,000, that makes around 500,000 new strokes every year. So this is a large number for a country with health resources like ours. There was a small study in KPK that has shown a prevalence of around 1.2% in general population, and mortality, as we said, is around 30, actually more than 30%. This is the old target from NINS in 1995. Sort of within 60 minutes we have to follow in terms of like hyperacute treatment. Majority of centers in established healthcare setup, they have reduced this time to like 30 minutes. But as we are starting this sort of a treatment, we are still sticking to this old treatment or the target regime. Time is brain. This statement has been revised again and again in all presentations. So 1.9 million neurons per minute in case of large or even small vessel occlusion. So that's why recognition is important. So we need to start teaching and training our junior doctors and also paramedics. So there are lots of validated tools in form of FAST, BFAST, Melbourne Stroke Assessment Scale, Cincinnati Scale, or Los Angeles Stroke Assessment Scale for large vessel occlusion. All have got their own sensitivities and specificities, and all established emergency medical services have got one of these tools embedded in their worksheet when they assess patient. As stroke neurologists, we are doing our job. In last 1 year, we have done multiple workshops in Punjab and KPK, where we have done neurological emergencies training of 1122 and Al Khidmat Foundation in the Capital Ambulance. There were, I think, more than 15 workshops that we have successfully conducted, and where we have trained all these professionals of emergency medical team with recognition of acute stroke and where to channelize and what to do in emergency. Transfer models, as we have discussed, we have got mothership model, where any stroke coming in to emergency medical service or to the caregivers should be transferred to the nearest comprehensive stroke center, where thrombolysis, thrombectomy, and acute stroke treatment is available. Other one is drip and ship, depending upon our resource, as we are running with Maroof International and Shifa, where patient can be dripped first in form of like thrombolysis, and then they can be transferred if they are candidate for thrombectomy to the nearest comprehensive stroke unit. And RISCAT trial has confirmed both results are comparable, provided patients are selected carefully and they are transferred appropriately. Telestroke, one of the emerging factor that is helping in reducing onset to needle time. The good thing is this is coming to Pakistan as well, and especially for a country like ours where health facilities are not that good and they are patchy, we can bridge that gap very well. At Shifa, we are starting this, I hope, a pilot study from next 2 weeks onward, where we are going to do thrombolysis from home, initially in Islamabad, and then we are going to spread this to our center in Faisalabad. And I hope, if possible, next year I will be presenting that data for our telestroke services, and that can be adopted and replicated wherever you guys are working. Mobile stroke units, something futuristic for us, but again, something that is up and coming in all developed healthcare setups. It significantly reduces the onset to needle time. It gives an excellent triage. The patient is transferred to appropriate unit, and the onset to admission time is also reduced, as if patient is transferred to the unit, the earlier we shift, the better the outcome is. So all the complication and the 3-month survival and the outcome in form of modified Rankin scale is better. And all the trials, they have given very good results in terms of like 90 days modified Rankin scale wherever mobile stroke units are. When I was a trainee, we used to do audit for door to needle time, and our aim was 60 minutes, as we have already discussed. Then over the time, it was onset to the needle, but now things have even changed. It's basically onset to tissue window. In all those centers who have got multimodal facilities like CT perfusion with good artificial intelligence softwares like Rapid, or even it can be done manually, that is slightly time taking. It takes about 5 to 10 minutes if you are trained for that, or we can do diffusion flare mismatch. At present, there are at least 3 centers in States and 2 centers in UK who are basically practicing this with diffusion flare mismatch, because we have got MRIs at some places in Pakistan. If we have got stroke established on DWI, but it is not coming on flare, so we can utilize that time window for patient coming in with they can be candidate for thrombolysis. And all those trials, they have given good results in terms of 3 months modified Rankin scale, all those patients who are treated that way. Then in terms of like new medications, Actelize have been there for last about 3 decades with very good results. But now we have got tenecteplase. This is one of the new kids in the block. This is again genetically engineered mutant tissue plasminogen activator that has got quick onset of action and slightly longer duration of action. That makes it a rapid bolus rather than infusion over 1 hour. That is tolerated very well against plasminogen activator inhibitor. So in case of large vessel occlusion, especially where thrombectomy is planned, this is a better choice as compared to Actelize. That doesn't mean that Actelize is going to go out of fashion. We have got another addition, and we can use it for our patient. All other trials, even the dose escalation from 0.1 to 0.4, that has given favorable results. And the other trials like Australian TNK trial in 2012, though it was a small patient group, but that has also given good results for 0.25 milligram per kilogram patients, especially in case of large vessel occlusion. So as a result of all these meta-analyses, it is coming in guidelines now. So these are all trials they have completed with good results, and these are the trials that are up and coming. So hopefully this will be a part of guidelines. And in established healthcare setups, as I said, they have been using tenecteplase along with alteplase in all patients who qualify for that. So American Heart Association guidelines supplemented in 2019, they have given it 0.25 milligram per kilogram for all those patients who are going for thrombectomy, and for 0.4 milligram per kilogram for those patients who are not going for thrombectomy, like small vessel occlusions and for lacunar infarcts. ESO has followed the same, but they have given 0.25 milligram per kilogram for both large vessel occlusion and for small vessel strokes, whether patient is going for thrombectomy or not for thrombectomy. Endovascular, I will not go in detail because that is beyond the scope and that's a separate topic. But after Mr. Clean and Swift Prime and trial in last 10 years, that is actually an established setup in terms of like all patients coming in with large vessel occlusion. Initially it was with aspect of like 7-8 plus and with large vessel occlusion on CT angiogram within 6 hours, but after dawn and diffuse the time window has increased up to 24 hours. We are practicing in Islamabad up to 12 hours depending upon individual patient selection, CT perfusion and diffusion flare mismatch, either using CT perfusion or MRI. This is for young doctors, just the pathway we follow. So initial assessment, still CT is the gold standard within time window, 4.5 hours, more than 4.5 hours. And then whether patient is for thrombolysis arm or thrombectomy arm, or if it is more than 4.5 hours, then neurology assessment and thrombectomy depending upon patient's selection. And we can use multimodal imaging like CT angiogram, CT perfusion, and we can take a decision for thrombectomy. Now coming to the situation in Pakistan very quickly, we have got only 16 centers from north to south with 14 centers who have got established stroke units, but number of beds in all stroke units are very limited as compared to the population and our disease burden. Availability of CT MRI is also very limited, it's around 300 plus, and cost of TPA is increasing every day with changing dollar price. It's actually not 2000, that was the time when I wrote this presentation, it is more than 2000. Okay. So CT head is mandatory. Mechanical thrombectomy is only at 5 centers, 3 public sectors and 2 private. Teaching, again, one of the most important, because more we teach, better we will be in future. There is one public sector at present, but a second public sector is starting neurointervention training in Lahore, LGH and SIMS. We have got only 2 vascular medical fellowships, one in Shifa and one in Karachi, Aga Khan. And from our part, from Pakistan Society of Neurology and Pakistan Society Stroke Society, we are running awareness programs for GPs, nursing, and for general population. This is just our data very quickly. We started in 2014, first patient was thrombolized in 2015, and we started thrombectomy in 2018, and since then, alhamdulillah, we are running well. We are presenting our results nationally and internationally. So total patients admitted with acute stroke was around 3,200. Out of them, around 10%, that is actually a good number for a new service who underwent thrombolysis, and around 1%, 35 in total actually, who underwent thrombectomy. Our mean age is around 67, with predominantly males around 77% as compared to females. Majority brunt is by anterior circulation, right and left, but few posterior and anterior circulations, ACA infarct, sorry. And our onset to arrival time was 96 minutes, but look at the range, it can be as early as 8 to 210 minutes, so we need to involve our general population in terms of public awareness. Door to needle time is 68 minutes, still not near our targets, but again, if you look at the range, it is 20 to 192 minutes. Again, awareness is important. Door to first pass in case of mechanical thrombectomy is 168 minutes, but 59 to 226, so we need to improve, but still we are improving our service. And this is important, from those 35 patients, about 27, that is good number, they reached like ticket grade 3 or 2B, and they are basically a useful member of society, back to normal. 5 were like intermediate, and 3 have not done that well. Our stroke-related mortality was around 8%, and hemorrhagic transformation and general bleeds, they were like international standard around 5 to 6%. Future directions, just last couple of slides. I mean, ischemia doesn't only affect neurons, it affects rest of the brain tissues as well. For young doctors, it is different in different patients, and basically it is dependent upon lots of factors where we can protect our brain. In terms of like collateral circulation, we have to keep it open with good blood pressure control, keeping MAP in reasonable limit of around 95 to 100, good metabolic control in terms of like diabetic and glucose control, keeping patient temperature at around less than 37.5, and age of patient, definitely it matters, but that is something that we can't modify. Future, that is most important, especially with the audience like you who can do something different. First, we have to train our EMS because people are still reluctant, and we need to teach them the directions. Stroke units, we need wherever we are working, we need to utilize whatever resources we have got. We need to explore the concept of early warning devices, like patients coming in with atrial fibrillation and heart diseases, and we have to involve our pre-hospital treatment setup, and like our primary care physicians, they need to be integrated with our secondary and tertiary centers. So situation not that good, but still we have got ray of hope, so I hope future will be better. Thank you. Any questions? We are using solitaire.
And is it CMCT or you do conventional angiography?
No, we are using conventional angiogram. I mean, all the patients.
But we are using solitaire.
We are using solitaire, but majority they are basically depends upon the cost as well.
How much is solitaire costing?
Solitaire is, I think, around, I don't know the exactly top of my head now, but it was like more than
the new one is solitaire FR.
I think, but I think that is more than 350,000 or something. I don't remember exactly the cost, but it is more than, because the first day cost, if we do thrombolysis and thrombectomy at Shifa, is around $1 million. So, I mean, cost is a big factor.
What is the maximum time window that you are?
We are going up to 12 hours actually.
So you are not doing refusing 10 hours. 12 hours.
No, we are not refusing 12 hours. So all young patients who are less than 60 with good brain, large vessel occlusion, we are going 12 hours, and we are planning up to go to 24 hours because we don't have got too much number, but like as we have got like 35 plus, and now we have got at least 2 people who are trained. We have got Dr. Atif Rana and we have got another IR consultant.
And what is your successful reperfusion rates?
I mean, they are very good. As I said, 27 out of 35, they are back to their normal routine, they are working. One has not done that well, but he was like 83-year-old gentleman, father of a doctor, and actually we were reluctant. He was like around 10-11 hours, so he has not done well. Otherwise we have retained like good perfusion.
We were just discussing with Dr. Javed Akram Saab. Actually, lack of awareness is the main
big issue
factor, and so many patients, they report late. So as I suggested last year in your last conference, also to have, and now that Professor Javed Akram is health minister these days, we should have a dedicated health channel, health TV channel, where awareness should be given to the public when and where to act in what time. For example, in stroke, one has to act early,
fast.
And I also suggested to Dr. Somia also that TV channel is a must. Health.
Sir, TV channels, social media, print media, everywhere. I think.
Social media पे लोग दूसरी वो TikTok वगैरह देखते हैं ज़्यादा.
Sir, we can make TikToks. I'm in process of making an animated video for children, because last year on Stroke Day we launched a book for children. और अब I'm planning कि पिंडी इस्लामाबाद में जितने भी schools हैं, I'm launching that book for children. बड़ों को educate करना मुश्किल होता है. They see TikTok more, I think. So, and that जो हमारी वो book है, we are just making it on a short sort of an animated video as well. So we need to go to the schools, emergency medical services, young doctors,
But
we
it's
need-
not possible to reach to every school or every where. What we require is a dedicated health TV channel
Yes.
for awareness of the public.
I mean, everything will help. Everything will help. So whatever channel is available, we should utilize